Let us starting from question number 11. So the cardiac catheterization is performed on a 7-year-old boy. The image below shows the pattern of oxygen saturation in the patient's cardiac chambers, and outflow tracts structural abnormalities are not shown. Okay, like this one, if we look at this, superior vena cava, the pressure is 70%, then right atria 70%, then right ventricle 81%, then pulmonary artery 81%. And if we go to the lungs and then came back to the left atria 96%, in right and left ventricle 96%. Okay, um, this patient most likely his which of the following findings on physical examination? uh, Please listen this and then give the answer. So, option A, bifid carotid pulse with brisk upstroke. Option B, continuous murmur over the upper precordium. Option C, decreased femoral to brachial blood pressure ratio. Option D, fixed splitting of S2 on cardiac auscultation. Option E, hollow systolic murmur over the left sternal border. Option F, mucosal cyanosis and fingernail clubbing. So pause it and give the answer. So the correct answer for this question is hollow systolic murmur over the left sternal border. Why? Let us see to the explanation. Because this case is related to the VSD. Why? You would say why? If we see to the pressure over here, if we came from superior vena cava to the right atria, the pressure is same. Okay, then if we go down, the pressure shouldn't be increased over here from the right atria to the right ventricle, right? But over here this has been increased, right? And after that, when we go to the pulmonary artery, the pressure should remain the same. Yeah, it has been remained the same. Okay, then it would have gone to the lungs, and then when came back to the left atria, the pressure in the left atria and left ventricle is the same. Okay, so if we see to the explanation, what is happened, what would have happened over here, the pressure in the left side of the heart would have increased, right? And there might have some hole over here which would have allowed the blood to flow from the left side toward the right side. So that's why this pressure would have increased, right? So that's why this is the case of VSD, ventricular septal defect. And the VSD sound can be best heard, uh, ventricular septal defect, that could be best heard, and the murmur would be of hollow systolic murmur type, right? And that could be best heard at the left sternal border, right? Why not the other options? Let us see to the explanation further. But what if the pressure over here was increased, let's say, uh, then this one superior vena cava, right? Let's say if here the pressure was, let's say, 80, right? Now that would be the case of ASD, atrial septal defect. Why? Because let's say, as we can see over here, let's say the pressure in the left area is 96%, right? And if, let's say, if there was a hole, right, then this blood would go toward this side, and that would have increased this pressure, while normally this pressure would be the same, like just like in this case. But if it was increased from 70 to 80%, then that would be the case of ASD, right? As I mentioned over here, this is the case of VSD. So there might have some hole over here which would allow the oxygenated blood, so that's why this pressure would be increased on the right side in the right ventricle, right? So this patient has an abnormal increase in oxygen saturation uh, between the right atrium and right ventricle, right? As I mentioned, the normal uh, percent saturation of oxygen would be just like that, right? When it go from right atria to right ventricle, that would be the same. But in this case, but in that case, in the previous case, um, in the scenario that was increased, right? Let's say it was 80, right? So this is indicating the presence of left to right shunt, right? That is most likely the result of VSD. With smaller VSDs, blood is shunted mainly from left to right due to the high pressure differential between the ventricles. As a result, right ventricular partial pressure of oxygen increases, but the person saturation increases, right? But left ventricular saturation remains relatively normal. Larger VSDs allow equalization of chamber pressures, which results in more bidirectional maxing and decreased left ventricular percent saturation. Right atrial percent saturation remains normal with VSDs of any size, unless tricuspid regurgitation is also present. Turbulent blood flow across a small VSD produces a loud hollow systolic murmur, best heard over the left uh, lower sternal border, right? This is important. So this was pointing toward VSD. This murmur may be absent in larger non-restrictive VSDs, right? Due to decreased resistance across the VSD and lower transseptal pressure gradient. One option A, bifid carotid pulse with brisk upstroke, that is spike and dome, is characteristic of hypertrophic cardiomyopathy. This is the characteristic of hypertrophic cardiomyopathy, right? A condition with dynamic left ventricular outflow tract obstruction during systole, right? The percent saturation in cardiac chambers remain normal in that case, right? But in this case, as they have mentioned, there was variation in pressure. Why not option B? Precordial continuous machine-like murmur. That is the characteristic of PDA. Point to be noted. PDA, machine-like murmur. Okay, which is a continuous type of murmur, which produces isolated pulmonary artery percent saturation elevation. Why not option C? A decreased femoral to brachial blood pressure ratio is found in coarctation of aorta, right? This is important. Which doesn't alter right ventricular percent saturation, right? Then fixed plating of S2 occurs with ASD. This is really important, and I talked about this thing, right? Which causes increased percent saturation in right atrium, as I mentioned, compared with the vena cava, but identical right atrial and ventricular percent saturation. VSD may result in wide splitting of S2. We will talk about this thing. This is the important characteristic of ASD, right? Due to increased right ventricular volume causing delayed closure of pulmonic valve, right? There will be little bit delay in the closing of pulmonic valve, right? However, fixed splitting of S2 is more indicative of ASD. This is really important, right? If there is fixed splitting of S2, that would be the case of ASD, right? Equalization of left and right atrial pressure minimizes the respiratory variation and ventricular blood flow. Why not option F? Mucosal cyanosis and finger clubbing, right? Point to be noted. Mucosal cyanosis and fingernail clubbing may be observed in cyanotic congenital heart disease are late features. These are the late features, are VSDs. For example, Eisenmenger syndrome, right? These can be seen in congenital, cyanotic congenital heart disease. They mean to say if the shunt is from right to left, right, they will cause cyanosis, early cyanosis, right? But as we know, in case of VSD or ASD, initially, that is left to right shunting, right? That is left to right shunting, so they will not cause initially cyanosis. But if they are in the chronic situation, that would form Eisenmenger syndrome, right? That would be converted to Eisenmenger syndrome, and then the shunting would be reversed, that is right to left, right? So that would cause what? Cyanosis, right? Okay. So blood flow across the VSD in Eisenmenger syndrome is right to left due to elevated pulmonary vascular resistance, resulting in decreased partial pressure, person saturation in the left ventricle, right? So that would decrease the person saturation, right? Not increase. Okay. So the increased blood oxygen saturation between two right-sided vessels or chambers indicates the presence of left to right shunt. If the abnormal oxygen increase occurs between the right atrium and right ventricle, VSD is likely present. Small VSDs produce hollow systolic murmur. Point to be noted. Small VSDs, right? Okay. That is loudest where the lower left sternal border. That is LLSB. LLSB, right? In the next question, we have a 78-year-old woman comes to emergency department due to 3-day history of intermittent but progressive substernal chest pain. Medical history includes hypertension and hyperlipidemia, but the patient has had poor adherence with her medication and outpatient follow-up. She has a 30 peg year smoking history. Okay, there is ST segment elevation and pathologic key waves in lead 1 AVL V2 to V5. Okay, the patient refuses percutaneous coronary intervention, is treated medically. On the 5th day of hospitalization, she experiences severe dyspnea, sweating, and hypertension. Physical examination shows raised jugular venous pressure, no heart murmurs, and clear lungs. She rapidly loses consciousness and becomes pulseless, and the subsequent resuscitation attempt is ineffective. Which of the following most likely contributed to this patient's death? Let us hear this, then we will talk about the options. Option A, blood accumulation in the pericardial space. Option B, complete rupture of the papillary muscle. Option C, rapid reperfusion of the ischemic myocardium. Option D, rupture of the interventricular septum. Option E, true aneurysm of the ventricular wall. So pause it and give the answer. So the correct answer for this question is option A. Why? Let us see to the explanation. Right? This is the case of left ventricular free wall rupture. How? Because this patient was initially admitted with chest pain and ST segment elevation in the anterolateral ECG leads, finding consistent with ST elevation MI, right, of the left ventricle. Several days later, her abrupt onset dyspnea and hypertension were most likely due to left ventricular free wall rupture, a potential mechanical complication of transmural MI, right? Left ventricular free wall rupture usually occurs within 5 days, but can occur up to 2 weeks following MI. Okay. During this time, the infarcted myocardial wall is substantially weakened by coagulative necrosis. So this is important. Coagulative necrosis occur in case of heart. Okay. Leukocyte infiltration and enzymatic lysis of myocardial connective tissue, and may be unable to withstand the shear stress generated by the high pressure left ventricle. Delayed reperfusion or absent reperfusion is in this patient increased myocardial damage. Okay, further weakening the left ventricle wall and increasing the risk of rupture, right? With left ventricular rupture, blood abruptly fills the pericardial space, right? As I mentioned, the blood. So, why? Because the blood abruptly fills the pericardial space, that would result in hemopericardium and acute cardiac tamponade, right? With rapidly increasing intrapericardial pressure, right? At onset, patients may experience dyspnea, diaphoresis, and sometimes chest discomfort. Diastolic filling of the relatively low pressure right sided heart chambers is abruptly restricted, causing jugular venous distension, right? Because of that pressure, right? And blood flow through the pulmonary circulation to the left side of the heart drops uh, precipitously. The lungs remain clear, right? Because there is no flow uh, uh, to that side. Okay. Cardiac output profoundly decreases, resulting in hypotension, right? And obstructive shock that rapidly leads to cardiac arrest. Okay. Why not option B and D? The papillary muscle rupture causing acute mitral regurgitation, and interventricular septum rupture causing a ventricular septal defect VSD, right? Can occur acutely, that is within uh, three within 2 to 3 days or within 5 days of MI. Both defects typically cause a new holosystolic murmur, right? They would cause new holosystolic murmur and lead to left ventricular failure with pulmonary edema, right? With pulmonary edema. Cardiogenic shock with hypotension commonly develops, but lung crackles would be expected in this on this occasion, right? But in this case, is they have not mentioned such type of things, right? So they are absolutely. Why not option C? Then why not option C? Ischemic reperfusion injury can occur when blood flow is abruptly restored to infarcted myocardium, and it may rarely lead to cardiac arrest, right? Via precipitation of ventricular fibrillation or profound myocardial contractile dysfunction. However, it is extremely unlikely in this patient who received no perfusion therapy, right? Okay, why not option E? Left ventricular aneurysm formation is typically a delayed mechanical complication of MI occurring after several weeks or months. Patients typically develop gradually progressive heart failure or angina. So the left ventricular free wall rupture is mechanical complication that can occur within 5 days or up to 2 weeks following transmural, that is ST elevation myocardial infarction. Patients usually develop acute cardiac tamponade, sorry, with hypotension and obstructive shock that rapidly leads to cardiac arrest. Uh, the points to be remembered are that there will be no pulmonary edema in this case. But if we watch to the if there is papillary muscle rupture and if there is interventricular septum rupture, that would lead to mitral regurgitation or VSD, right? Uh, they would cause pulmonary edema, right? And so the lung crackles would be there to lengthen. Okay. And why not option C? Because over here there is no reperfusion therapy and left ventricular aneurysm formation. This is a late phenomena.